I'm Dr. Michael Datola.
And I'm Megan Strong.
You're going to want to hang around and check out what a dentist did in this week's Case of the Week.
And when it comes to the news, the first story is quite the mouthful.
And a dentist writes in from Brazil to tell us about the intraoral critters he himself has seen. That and more on today's Chairside Live. Hey now, hello and welcome to episode 132 of Chairside Live. We've got a great episode for you today. Megan, how the heck are you?
I wish I could say that I'm doing great, but I can't really breathe through my nose and my ears are clogged and I'm getting over a cold.
You sound a little different.
I do.
I think you have the cold that I had a couple months ago, which a lot of my physician friends are referring to as the 100-day cold. This thing doesn't go away. It looks like it's going away and then it comes back again, but literally they're saying it's about 3.5 months.
Oh gosh, I'm like a week into it.
Oh,
that's depressing.
You're very early on.
Yeah.
And so do you already have now the ear blockage,
Yep.
the Eustachian tube blockage that I had?
What?
Do you remember what I did to solve my problem?
I do remember you had some sort of weird contraption.
I had a weird contraption that I couldn't order without a prescription from a doctor.
Right.
And I was comparing it to the Avio,
Sure.
where patients just can't order the Avio online. And I had to get a doctor's prescription to order this. But it's a wonderful little device called the ear popper. And I think a lot of people out there, a lot of dentists might be suffering the same cold. Let's go ahead, and it says it's the ear popper 1200.
Okay.
So there was a lot of other versions. This
Right.
is the 12th one.
Here we go.
Let's give this a try. You're going to
I'm scared.
swallow once, then
Okay.
you're going to put it up to your nostril, plug the other one, press the button so it fills with air, and then swallow, and it will push the air through
How
your
long
eustachian
do I
tubes.
let it?
If you do it any longer, about 3 seconds, you won't be able to swallow because you'll feel like your body won't want to do it.
Oh gosh,
So
I'm nervous.
let's just try 3 seconds
Okay.
here.
Didn't do anything. I
Yeah,
did it wrong.
you have to leave it up there, and
Well,
you have
I
to
got
swallow
nervous.
while the air is still going.
Oh, got it. Okay. Take two.
I can duct tape it to your head if that'll help.
No.
Okay.
I can't do it.
Let me try. Yeah, okay, it worked. My ear's a little plugged. I didn't even realize that.
Wow.
You just got to force it. Force it.
Whoa!
Oh, did it work?
I think it re-plugged it.
No. That was it opening and then closing.
Oh.
Yeah, so it doesn't open it permanently. It just opens it enough so air passes through.
Wow.
It equalizes the pressure in your head, and it keeps the tube open so you won't get an infection. And I'm pretty sure the 3 seconds right before it worked is going to be on the blooper reel. I'd like to remix. I saw a lot of this going on. I'd like to remix that to some kind of song. So
Great.
thank you for
Yes,
doing that and
of
demoing
course.
that somewhat on the air for all of our viewers. We've got an interesting case of the week for you today. It's an anterior bridge that the doctor prepared, took a nice impression, did some nice preps, and set it in. It's being done in conjunction with a CAD/CAM lower partial, and we'll take a look at that because I want you to see what a 3D printed partial looks like and some of the advantages of that. But the really interesting thing about this case is how the doctor took the bite registration. It's honestly one of the first times I've ever seen something like this before, and the doctor took an ordinary household item and used it to give us what ended up being a very accurate bite registration. Let's go ahead and take a look at that now. This is an interesting case that I happened to see today. Thought I'd share it with you. Here's the impression from the dentist. It's the maxillary impression. This is for a 6-unit bridge, as you can see, from cuspid to cuspid. And it's taken in a stock plastic tray with 2 phases of material. We can see some evidence of material beyond the margin, which is something that really excites me. And some of them, it's kind of a close call, but we did not have a difficult time trimming these dies. The technician said it was pretty straightforward, no issue. This is the one with the soft tissue on it that's going to be used to seat it. The first thing is the doctor prescribed a PFM bridge for this 6-unit bridge. And could you have done this in solid zirconia? Yes, you could have done it in solid zirconia. But there's nothing wrong with doing it in a PFM as well. I've said many times on this program that, well, I haven't done a single unit PFM since 2009. I continue to use PFMs for bridges. Now, I might not have done it exactly on this particular bridge because the bite forces are definitely weaker, much more so in fact than in the posterior. So The fact that, that solid zirconia bridges can fracture more, especially with multiple ponics, than, say, a PFM bridge in the posterior, doesn't necessarily drive me away from this. But you can see how when we talk about the rule of 27, we've talked about that before, about how the vertical connector and the horizontal connector, especially on a posterior bridge, needs to be 3 millimeters by 3 millimeters. It's difficult to measure as a dentist, even if you try to take calipers and measure this and measure it and say, oh, look, it's, it's 5 millimeters tall here. Well, it's really not, though, because we're looking at the ceramic material too and not just the metal substructure. But typically on anterior bridges like this, because we can make this vertical connector as tall as we can on anterior teeth, this ends up making these bridges rule of 27 compliant, because if you'll recall, the actual rule of 27 is the height of the connector squared times the width. And the reason the height is squared is because that's the more important of the two measurements, because all the biting forces are coming this way against the vertical component of the connector. And so if you have a vertical connector that's tall, say 5 millimeters tall, you can get away with something thinner that's maybe 2 millimeters or 1.5 millimeters facial-lingually, because of how tall that connector is. Oftentimes in the posterior, the opposite's true. We have a really short vertical connector, and you would have to make the width of the connector unusually wide to try to make it work. So this is probably a bridge that could have gone either way. Nothing wrong with doing a PFM bridge here, but probably could have been solid zirconia at the same time. So kind of the doctor's call on which way you want to go, whether it's going to be a PFM or whether it's going to be a solid zirconia bridge. The interesting thing on this case is that when you look at the opposing model, the patient is missing a lot of posterior teeth. In fact, I'll bring that in right now. It's a little difficult to see because the doctor is having a partial constructed at the same time. So this is what a CAD/CAM partial looks like if you haven't seen one before. And this gets printed up on a 3D printing machine. We've looked on the show before, and I've shown you how we can print up a PFM coping. We can print up an Emax crown at a resin and then invest it and burn it out. And so this is a CAD/CAM partial, and the fit on these is really unbelievable, and that's why we've gone towards these rather than hand waxing them. So this has been designed in a CAD/CAM system on the computer, and all the casps have been put in after the model's been scanned and the undercuts have been found. So rather than using a surveyor like we did in the old days, we've got the CAD/CAM accuracy of knowing where the height of contour, knowing the undercut measurements, kind of like we do with looking at reduction on crown and bridge cases. CAD/CAM allows us to really see everything and measure it and quantify it, know exactly where it is. So on some of these clasps, you can see, just to keep them from breaking, that we have a little support structure that goes over the tooth. So this is going to be cast in metal and then cut off afterwards. You can see this cross arch bar here on the lingual to provide support for that as well. So this gets printed on that 3D printer. It's probably not strong enough to try it in intraorally. As you look at this, you might think, wow, I could have the lab send me this. I could try it into the patient's mouth, see if it fits, send it back, and then have them sprue it. Right now, the resins that we're using, the available resins, aren't quite strong enough. If you try this in, and especially when you pop it out, it's very easy to break the clasps on these. So we're looking for a stronger resin. And we do kind of envision a day where we can send this to you, you try it in, and without us having to go all the way to finish, you know whether or not this is going to fit. And then we process this exact same frame for you and send it back, so you're very confident at the delivery appointment about how this partial is going to pop into the patient's mouth. We've sprued it in 3 spots. We have our little reservoir here. So this will be lifted off of here. We don't need a refractory model anymore because it's not waxed on. This will be very carefully lifted off of here by the technician who finished this. And then it will be invested and then burned out and then cast in metal in this exact same shape. But really the CAD/CAM part where we scan the model, so it's even more important to get very clean impressions like you've hopefully been doing in the past for these. We scan the model and design it in a CAD/CAM environment so we can see exactly where the undercuts are. We can see exactly how long these clasps have to be. And so I'm just wanted to show you what a CAD/CAM partial looks like after it's printed and before it's cast. Most dentists haven't had an opportunity to see these before, but we're lacking a lot of posterior support across from these teeth. And the last thing I wanted to show you was the doctor's creative use of bite registration material, and it's a blue moose bite that was taken. And you can see that what the doctor did was leave one of the temporaries in place to act as an occlusal stop. So obviously, when you have all the teeth prepared, as you have here, and you're going to have the patient bite down, and there's no posterior teeth that are going to be in contact with these, the patient's going to overclose. And so what the doctor did was leave one of the temporaries in, sitting on the lateral incisor as a stop. You could have made an argument for doing it on both of the cuspids, maybe, so you had a stop on both sides. But as long as it was a solid stop where the patient closed against that lateral and didn't move, didn't slide, then you can take the bite registration and maintain the vertical like that. And bonus points to the doctor. This might be the first time I've ever seen this. And this is, we'll zoom out just a little bit to give it some perspective. This is a coat hanger that has been fashioned into a bite registration. And so essentially it looks like what the doctor did, I wasn't there, but it looks like he sent the assistant to the closet, took one of his lab coats off it, and then cut the coat hanger and then fashioned a handle out of it, and then put red wax around here to help hold this gauze on. I'm not even sure I had this laying around the office. I don't know where I would get this. I would have tried maybe toilet paper. Maybe a patient bib actually would have worked well. And then squirt. I guess you got to make sure this will fit in the patient's mouth. You don't want the ends of the coat hanger lacerating the cheek. And so you bend it in to make sure it'll fit in the patient's mouth. Put the temporary in place, maybe with a little temporary cement, or just cure it on with a little Flowable, or maybe there's enough retention to keep it on there. And then squirt your bite registration onto both sides and have the patient close into it, have them open again, and then you're able to have it all in one piece. Sometimes these stiff bite registration materials like Blue Moose have a tendency to break, but you can even do it in thirds. There might be, you could see sometimes we'll do it in thirds. I can't tell if the doctor did this in thirds or if it broke subsequently. But big props to the doctor. This is the first use I've seen of an intraoral use of a coat hanger. And so I just wanted to give props. The doctor did some very nice preps, took a nice impression, and we're going to be able to send back a nice CAD/CAM partial in addition to the nice PFM bridge that we have here. But bonus points for thinking out of the box and using a coat hanger intraorally to get this bite registration. The closest I've come to this is sometimes I'll use old burrs and I'll nail them into the wall and then hang like a diploma on it or something like that. But I've never gone reverse and taken like something like an ordinary coat hanger and used it in the mouth. That's as MacGyver as it gets in dentistry. So hats off to this doctor for a unique way of getting us an accurate bite registration.
Thank you for that, Dr. D.
You're welcome.
Now let's go to a segment we call Viewer Mail. For this week's viewer mail, we actually have two different letters, and the first one comes from Dr. James Beck from Conway, Arkansas, and he writes, "Dear Dr. Totola, my favorite crown margin is the shoulder margin. It is just a fast and easy prep in my hands. Is the shoulder margin suitable for most materials? Are there any materials in which a shoulder would not be recommended? Thank you."
James, that's a great question. And I love the shoulder margin too. In fact, I often kind of blur the distinction between the deep chamfer and the shallow shoulder because I don't even know where one stops and the other one starts. But that reverse preparation technique that I like where we use the round burr gives you whatever you want to call it, a deep chamfer or a shallow shoulder. In fact, it all depends on the size of the round burr that you're using. The one that I traditionally used for many years was 2.1 millimeters across. We've shown it on the show before, and now I'm using smaller ones, 1.4, 1.6 for some of the higher strength materials like Bruxer, and even for Emax. That 2.1 was for bilayered restorations like lava and PFMs and things like that. So as to your question, is there any restoration or any restorative material that does not like a shoulder margin? No. They absolutely all do very well with it. Even if you take a high strength material like Bruxer, we always say that a feather edge margin's okay, but a chamfer margin is preferred, and certainly a shoulder margin preferred as well. So Bruxer, yes, will tolerate a feather edge margin, but there's more of a chance that it'll chip while we're milling it. There's more of a chance that if you're adjusting it, something could happen. There's even a very small outside chance it could chip while seating it, but I've really never seen that happen. But if it was thin enough it could happen. So even though it will tolerate that, it certainly prefers, while it's being milled or being adjusted or handled, to have a chamfer margin, or as you suggested, a shoulder margin. Even cast gold, which can certainly have the thinnest feather edge margin of all. You can take a sandpaper disc and really thin that out as you burnish that margin. That does fine with a shoulder margin as well. So shoulder margins are absolutely recommended for bilayered restorations like PFMs, like lava crowns, or any porcelain fused to zirconia. But it'll work with any of the monolithic crowns as well. So if you're looking for a universal margin that will work on absolutely all indirect restorative materials, it would absolutely have to be the shoulder or the deep chamfer, like I said. But that's, you get what I'm saying. It's that same type of margin that you're talking about. If somebody had written in and said, oh, I love feather edge margins, can I use it on everything? Well, absolutely not. I mean, you could use a feather edge with a PFM, but you'd have to specify that you wanted a metal collar, and then it would be fine, because any metal can be taken to a feather edge, but Emax does not do well and is contraindicated with feather edge margin. So if you're looking for a universal type margin, absolutely, the deep chamfer or the shallow shoulder is the way to go. So that's a great question, and I'm glad you like cutting that margin, because our technicians love seeing it. It's very easy to identify, easy to build up the material. The material, regardless of what it is, will do a great job at that thickness of the shoulder of blocking out a dark stump shade if it's an endodontically treated tooth or maybe has a metal post and core. So much like you, that is my favorite margin and the one I use anytime I can, with the exception of maybe a lower second molar where we've broken off a cusp and we're going to do a solid zirconia crown. I just can't get back there to do that shoulder, or I'm trying to do minimal prep. Then I'll be okay with a chamfer or even a feather edge if I have to, although it's not my preferred margin. So thank you very much, and I completely agree with you that if you're looking for a universal margin, that's the way to go.
Nice. Okay, and then our second letter comes from Dr. Ann Mudd from Kentucky, and from Louisville, if you will. And she says, Dr. DeToll and Megan, hello. I just watched episode 131 of Chairside Live. I was amused by the story Megan told of an Arizona woman that saw the face of Jesus in her molar. How ridiculous, I thought. Later that day, I had a new patient come into my office. Her radiograph showed that she was in need of a very thorough cleaning. Upon closer inspection, lo and behold, there was something very, very peculiar with tooth number 3. Needless to say, I'm a believer now. We will be sure to give this tooth the best of care.
And here's the x-ray.
Oh my gosh!
And I know you're not a dentist, but I guess I don't need to point out which one's tooth number 3.
No.
But it's the only one that has the apparition of you,
What?
it turns out, inside of it.
Holy
now the
molar.
first time I got this, when I got this email, it was on the weekend on my iPhone.
Okay.
And I pulled it up and I looked at the image and it was tiny.
Sure.
Not only could I not tell it was you, but I was like, oh my God, that is much more realistic than the woman who saw Jesus. This one really looks like a face, and I was blown away. So I kind of fell for it, because I saw it on my iPhone first, hook, line, and sinker. Then I blew it up and noticed it was you.
It was me.
And so it'd be funny if they do a root. And by the way, your face is on a filthy tooth. These are wings of calculus and tartar that are here. This is somebody who hasn't had their teeth cleaned for probably 8 to 10 years. There's a lot of perio breath going on here.
I'm trying to clean it from the inside out.
I'm just saying, in this particular x-ray,
Yes.
your face does not smell very good. And I apologize. And look at that open margin. See a little open margin on that crown? I hope we didn't like that. But it looks okay with the rest of the root canal. But yeah, you're on a tooth that needs some serious cleaning there.
Okay.
But thank you, Ann. We appreciate
Yes.
you send that in. Anytime you see an apparition in a molar or a central incisor, whether it's my face or Megan's or one of the messiahs of a major religion, feel free to send it in to us, because we'd love to see it.
Okay, and what do we have for them?
We have, I'm going to send Dr. Beck, because he happened to ask about different margins, like shoulder margins and the preferred one. I'm going to send him one of our reverse preparation kits.
Okay.
Because I know he likes that margin. I don't know if he's tried it yet or not, that technique, but it's going to have that round diamond to give him that margin. And what would you suggest that we give to Ann?
Well, her name was Ann, so I'd suggest that we give Ann this photograph.
You lost me. Ann, because her name's Ann?
Yeah, no, you said her name was Diane. Her name's Ann.
It's Ann.
Yeah.
Yeah, Ann Mudd.
Yeah, you said Diane.
Oh, I did say Diane?
Yes.
Oh, I'm sorry. I didn't mean to say that. I knew what it was. I was reading it as you read it.
Okay.
But I'll tell you what, maybe we can draw a picture of her inside of one of our heads.
No, I figure she's got a picture of me inside of a tooth, so she should have a picture of me and you outside of a tooth. Also, real quick, this is when I had short hair and I wasn't pregnant, but I look like, in this photograph, I was giving you quite the stink eye. Wow.
It looks like you're angry at James, the producer there, not me.
Probably.
But you're looking right in his general direction in that picture. All right, we will be sure to send that off. And did you have one more thing you wanted to read today?
I do, actually, because now we're going to a segment we like to call the YouTube Comment of the Week.
Hello, YouTube.
Okay. This week's YouTube Comment of the Week comes to us from Dr. Lewis. I'm not even going to attempt to pronounce your last name. I apologize. He says, awesome, funniest Chairside live ever. Loved watching you guys. By the way, I'm a dentist from Brazil and also have seen a case of maggots in the mouth. Those sneaky maggots.
Well, sneaky maggots reminds me of sneaky meaties.
Sneaky meaties, my famous culinary delight.
Dentistry is really, blowing up in Brazil. All the reps you talk to, it's very hot. It's hotter than it is actually here in the United States in terms of its growth rate. It's really becoming available. So maybe they're seeing, a lot of people who haven't seen the dentist before. But that's surprising. I don't know if there's any U.S. dentists who have seen maggots in the mouth before. That's amazing that he saw that. And at least I know a guy now who saw maggots, a friend of a friend.
Right.
So I kind of like that story.
I don't so much, but I love that he thinks Chairside Live is funny because obviously it is.
Right. I'm glad he found that funny because he's seen it in real life. Oh, I know.
Yeah.
I know. I'm eye candy. Well, thanks for that. This just in. Do you have some news?
I do.
Okay.
A dad and daughter duo in New York just made history with their tongues. Guinness Book of World Records awarded the pair with a certificate for the world's widest tongues. The dad holds the record for the male category and the daughter for the female. The man's tongue is 8.6 centimeters wide. The girl's is 7.3 centimeters. They say they are proud of the title and are having fun showing people and watching people's reactions. Did you see this?
Wait, hold on. I think I heard you wrong. Hold on.
Oh, gosh. The air popper.
Did you say Guinness Book of World Records has a category for world's widest tongue?
Wait, what are the chances that, well, probably pretty likely if this is a hereditary thing, but that his daughter would hold the record for the female widest tongue?
Yeah, I don't think because the wife's tongue, we don't know what the wife's tongue looks like.
Oh, we do. I saw a video, and it's just normal.
It's like yours or mine?
Right.
Well, so maybe it's a recessive gene, but no, I don't think so. But I also think she's maybe the only woman under the age of 21 who has measured the width of her tongue on the planet.
Right.
That might be why she's in the book.
Maybe.
And if, let's say you had this huge wide tongue, would you want the notoriety?
No!
Right. You'd have me do tongue slimming surgery, right?
I would. Slim down my tongue, please. No, but they're going around enjoying the media coverage, showing people, going to people in the grocery store and showing them. I would keep this under wraps.
Hers that just looks like somebody with a big tongue sticking their tongue out. He looks like, that looks like a deformity. I'm sorry.
It absolutely does.
I'm
yes.
getting grossed out.
Right.
I'm sorry. Next story. Next.
Yeah. An office manager at a Bronx dental office was recently arrested and charged after she performed procedures on patients while the dentist was away. The 45-year-old woman worked on patients from November 2012 to August 2013. She scheduled appointments for discounted cash payments. Officials say she performed a root canal and even extracted teeth. One patient suffered an infection from the root canal, while another still has pain 2 years after treatment. The dentist eventually found out about the procedures from patients who had complications, and he fired her. She then tried to steal $20,000 from him. He immediately contacted the authorities.
Well, we've heard stories about people who are dentists in other countries coming here and doing dentistry without a license, and that's illegal, but at least they were trained as a dentist in another country. Right. We've heard about dental assistants having people in doing bleaching and maybe sealants and something like that. That's practicing dentistry without a license as well, but a chairside assistant is there watching dentistry all day long. This is the first time we've seen a front office person, an insurance specialist,
Right.
actually performing dentistry. Part of me is absolutely disgusted by this, and part of me is like wow at the same time, because this is just it's insane the amount of guts and chutzpah required to do this. It's insane that they would ever attempt that. It's
Right.
like me doing veterinary surgery, but it's crazy that she would even attempt this or think that she could, like a root canal and extractions and stuff like that.
Right.
My front office people would never try that, and I would like to challenge them to try that. I know it's wrong, you can't do that, but
Right.
it's amazing.
And she claimed that she was trained in her home country.
Oh, okay.
She
so
says that, but that has not been verified.
Okay. I'm going to choose to believe that she was trained as a dentist in another country,
Yes.
even though it sounds like an excuse, because otherwise it's just too far of a leap for my brain to make that a front office person would go, you know what? I've been filing an insurance claim on extractions for a while. I think I'm going to try one of
Yeah.
these.
And then
But I've
maybe my
always wanted to
chil-
see somebody
Right.
do that. Like, that would be a great game show. You pull someone out of the audience, and maybe they do like foot surgery or dental surgery, or they have to cook a gourmet meal. They never know. Just see what happens when, and you have somebody ready to step in if they start screwing up. But
Right, like when they do so much damage that the patient has pain still 2 years later after
Right.
treatment.
Right. Yeah, that's not good.
No.
And that's not going to be covered by his malpractice insurance, and she probably didn't have any. Well, that'll just about wrap up this
There we go.
wacky edition of Chairside Live. On behalf of myself, Megan, everybody here at the lab, and the whole CSL crew, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. Seriously.
Oh, so good.
And the first story is quite the mouthful. I don't know what I was saying. Why are you laughing so hard?
Because mine was so awful. I was making faces at the camera afterwards.
All right, for what am I doing today? Who am I? All right, you guys, listen up here.
All right, that about wraps
No,
it
it
up for
doesn't.
this.
I've got stories.
Oh. I was thinking, isn't there something almost? Well, thanks for that, Megan. Any news today?
Yes.
In this particular x-ray,
Yes.
your face does not smell very good.